talk is Neoplasia 2, and our presenter for today's talk is Dr. Anita Borges, madam, who is consultant pathologist at Center for Oncopathology at Tata Trust, Mumbai. So these are list of our participants who are going to interact with madam. So I will invite all participants to introduce by themselves one by one. So Dr. Ajit.
Good evening, everyone. I am Ajit Sahu. I am a second year resident in AIMS Bhubaneswar.
Good evening, everybody. I'm Dr. Sriram, a second year resident from KMC, Mangalore.
Dr. Raghav.
Good evening, everyone. I am Major Raghav. I'm a second year resident in AFMC, Pune.
Dr. Priyanka.
You can go to Akriti.
Yes. Good evening. I'm Dr. Akriti, second year resident from MAMC.
Dr. Asma.
I'm Dr. Asma Patel, first year resident from Tata Memorial Hospital, Mumbai.
Good evening, everyone. Myself, Dr. Sonal Karmur, first year resident at PDU Medical College, Rajkot.
Thank you all. So, moderators for today's sessions are Dr. KB Vatsala, who is Assistant Professor at Department of Pathology, Kasturba Medical College, Mangalore, and myself, Dr. Loma Parikh. I'm a consultant histopathologist at Zydus Hospital, Ahmedabad. Our host for our webinar host are Dr. Anita Borges, consultant pathologist at Center for Oncopathology, Tata Trust, Mumbai, and Dr. Sumit Gujral sir, who is professor at Tata Memorial Hospital, Mumbai. These are reminders. In case of connection interruption or low sound or no sound video freezing, please leave the meeting and rejoin with the same link. If the problem persists, please check in your internet connection. Please answer the poll questions by typing in the chat box, and please do not send requests for annotations to the presenters. These are disclaimers. These are few more disclaimers. These are list of our upcoming talks. On 10th August, we have slide seminar by Dr. Anita Borges, ma'am. And on 15th August, we have a lecture on relevant investigation to work upon a patient with fever by Dr. Tanu Singhal. So without wasting time, I would like to hand over to Dr. Borges, madam, to take over the session.
Okay, thank you so much. Let me start sharing my, thanks Loma. I think maybe you can see my screen now.
Yes, ma'am.
All right, good.
Full screen.
It's full screen. Is it not full screen for you?
It is full screen, full.
Okay.
It is? Okay, good. All right. So now we have, there's somebody already with a annotation request, and that is Ankita. Of course, I'm going to decline it, but I think they're doing it by mistake because they're pressing on that little squiggle to the right. Anyway, now we finished Neoplasia part 1, and I had, sort of given some homework. So let's see if we can start with that homework. And some of you said that you have gone through that, either attended the original lecture or went through the replay, and you know about the homework. Okay, so all right, let me start with somebody who has attended the last time, not attended, but at least I think you did. Raghav, did you attend last time's talk?
Yes, ma'am, I was there.
All right. So you know that this is the homework. There were 4 questions over here. And we talked a lot about retinoblastoma gene and its protein and TP53. And retinoblastoma gene was supposed to be, the gatekeeper, or sometimes called the governor of the genome, and TP53 was called the guardian of the genome, right? And they're very important in as tumor suppressor genes. And yet, when you have null mice. Raghav, do you know what is a null mouse?
Where the P53 has been knocked out.
Completely, and the retinoblastoma gene has been knocked out completely. So that means any null mouse for any particular gene is got both the alleles that have been knocked out. Yes.
Yes.
And yet these mice, and this is so important, retinoblastoma gene and T53. So why do they develop normally, Raghav? Because right from the embryo, the embryological stage, they don't have these genes. Any clue as to why this happens, Raghav?
Ma'am, one reason could be that there are other
Loudly,
alternate
if you can, Raghav. I don't know whether I'm the only one who's hearing it low. Can you come closer to
Am I audible now, ma'am?
Yes, you are. Can you, is there any way you can push it up a little bit more, Raghav? No?
No, I'm doing it.
Okay. Yeah, come on. Yes.
Is it better now, ma'am?
Oh, yes, I think so.
So, ma'am, one reason could be that there are alternate pathways also which can suppress the tumors apart from the RB and P53. So,
Yeah.
they can be the PI3K AKT pathway also.
Okay. So you said that there are, yes, continue. Sorry, Raghav. Finish your thought.
So, ma'am, one of the pathways, as I said, ma'am, can be PI3 AKT pathway, which basically regulates the cell growth. And apart from that, there are others also, but those are specific, like the APC pathway or the Notch or the Hedgehog pathway. So apart from these two main, there are other pathways also which may suppress the tumors.
All right. Did you notice, Raghav, that I said that the mice develop normally?
Normally.
Okay, what do we mean by develop normally? We're not really here talking about tumors, right? Okay, we talk about retinoblastoma gene and TP53 as tumor suppressors. But what are they actually doing, Raghav?
They're regulating the cell cycle.
Exactly. So they are regulating the cell cycle. And they are regulating the cell cycle in a very important kind of way. So, if their importance is such in the regulation of the cell cycle, then how is it that the embryo develops normally into a normal mouse? That's what we're talking about. The question of them in later life getting tumors is a secondary story, right? And because we talk of them as being such powerful protectors of the cell cycle. So why, and apoptosis and several other functions, at least as far as P53 is concerned, it's cell cycle, it is apoptosis, and so on. So why do these mice develop normally? And you were on the right track, Raghav, except you said that talked about it as being tumors. Because I hope everybody in the audience, and I hope the students who are there today understand that God didn't give us tumor suppressor genes, or for that matter, oncogenes, so that we could either suppress or produce tumors. Yeah, you understand that, Raghav, don't you?
Yes, ma'am.
Yes, so they're not there to either suppress tumors or, as in the case of oncogenes, to actually promote tumors. They have a normal cellular function. Okay. So now, yeah. So now tell me, you were really on the right track. So what did you say, Raghav? Tell me.
That there are other pathways also, like I started with the PI3K.
Yeah, there are many
AKT
other
pathway.
pathways. So I think, that we seem to or believe, because we are concentrated on tumors, that if you don't have retinoblastoma or you don't have TP53, that you will, at all, then there is something wrong with your entire genomic cycle, and you will probably not develop at all. Okay, let alone the question of having tumors. But that's not so. Nature is abundantly, has so many alternatives to one sort of thing. All right. And so the answer to that question is there is a huge redundancy in the system. So you don't have a P53. There is another pathway that will become important in those kind of animals. We can't do the experiment in humans, okay? Because we don't have really a P53 null system right from the time we are embryos. At least we don't know about such a thing. Yes, but we do know that if you have one P53 allele that is abnormal, during life, when the other P53 allele is knocked out, we get tumors, and that is known as the Lee-Fraumeni syndrome. And we assume that if there is a mouse that has got no P53 allele, then that mouse will not develop at all. But that's not true. There is a huge redundancy in the system. And once that mouse grows and is using another pathway, you may not get kind of tumors that you expect when both P53 alleles in post-natal life happens to be knocked out. Now with RB, it is a very interesting situation. The RB is very, very important in the development of the placenta. Trophoblast development is very dependent on having at least one allele of RB. So if you knock out both alleles of RB, mice will not develop. Okay, why? Because the placenta will not develop. But if you are able to keep that placenta going by putting back the RB in the placental, that means in the extra embryonic cells. What is the meaning of extra embryonic, Raghav? Can you explain? What are the tissues that develop from the extra embryonic part of the growing embryo, of the zygote? In other words, that is, what is embryonic and what is extra embryonic? Can you hear me, Raghav? Raghav is
Raghav is reconnecting. He lost the connection.
he lost the connection. All right, so maybe we'll ask somebody else. So maybe we can ask Ajit. Ajit, are you there?
Yes, ma'am.
Yeah,
Yes, ma'am.
Ajit.
Has some issues.
Extraembryonic refers to those
Yes.
other structure other than the embryo, like the placenta, umbilical cord. Those are the structures which help them
Placenta and
to survive.
umbilical cord. Anything else? What are the extra, apart from the placenta? There are two very important extra embryonic structures, no? So what are they? One is the placenta. You're absolutely right. Anything else? Which disappears, the placenta disappears. It's not there in after fetal life, right? That means once a child is born, there's no more placenta. The placenta withers away. Anything else that withers away and withers away earlier than the placenta, Ajit? Anything that you can think of? All right, Akriti. This is general knowledge. You know the question, Akriti?
Yes, ma'am.
What are the extra embryonic structures? No, Akriti doesn't know. All right. Is Sriram there?
Yes, ma'am.
So tell them. One we know is the placenta. What is another extra embryonic structure?
Can it be the umbilical cord, ma'am?
Umbilical cord. Okay. What else? No? And it disappears much before the placenta disappears. Asma? Asma, are you there?
Yes, ma'am.
Right. So can you think of something else? No? All right. Priyanka? Is Priyanka there or she decided to drop out? Are you there, Priyanka?
Yes, ma'am.
Right. Tell me, what is another important extraembryonic structure?
Yolk sac.
Excellent, Priyanka. Yes. So you have the placenta and you have the yolk sac. Okay. And in this case, when we're talking about retinoblastoma gene, all right, the retinoblastoma gene is extremely important in the development of the trophoblast. Okay, right from the beginning, those cells that are meant to become the trophoblast, you know that when a zygote is fertile, when the ovum is fertilized and a zygote is formed, there are some cells after the early, 8 stage, a cell stage, and the 16 cell stage, and then you have the blastocyst, and you know that there are parts of this structure that become the extraembryonic structures, that's the trophoblast and the yolk sac, and some that become the embryonic structures. Okay, so now here the trophoblast is very, very vulnerable if the RB, both the alleles are knocked out. But if you manage to replace the RB gene in the trophoblast and the placenta develops normally, the embryo develops without any problem at all. So the mice develop absolutely normally if the gene has been replaced in the developing trophoblast. So it seems almost as if the redundancy that we're talking about, which Raghav very rightly said, that there is a lot of redundancy in the system. Once, of course, the situation is set in stone, then the redundancy disappears. But during embryonic life, if one pathway is missing, then another pathway will take over the functions of this pathway. And it's very curious that you have the embryo and you have the extra embryonic tissue, in this case, the trophoblast. The trophoblast requires the RB gene, but the embryo does not. Okay, it develops very normally. Okay, let's go to the next question. All right, and the next question was what? Why are only a few organs the targets of cancer in the inherited syndromes? Anybody knew the answer to that question?
Yes,
I've given
ma'am.
the answer here, but did anybody find it out? Yes, anybody?
Yes, ma'am.
Sriram,
Mm,
did you find the answer to that? You know, no, that if you have, the Knutson's hypothesis.
Yes,
You
ma'am.
need, yes. And so why do you only get a retinoblastoma? Because every cell in your body has got one
Allele.
gene that is knocked out, and any other cell in the body, that cell could have the Knutson's, fulfill Knutson's hypothesis and have the other allele knocked out. So why are only a few organs the targets? So why only retinoblastoma? And you don't
Maybe,
get a liver cancer, or you don't get a skin cancer or anything else.
is it because once that mutation or allele is knocked out, and during the course of that cell's progression and the events that it undergoes, which are specific to its location and maybe tissue architecture, it becomes more susceptible to tumorigenesis, is one thing that I thought of.
You thought of. Yeah, that's a good answer, in fact, because can we assume that, the gene, whatever gene that we're talking about, in this case, we're talking about retinoblastoma or P53 or any other, whether it's APC, and why do we only get polyps in the colon, and sometimes we also get some mesenteric fibromatosis in Gardner syndrome and so on that is associated with APC. And we wonder, why is it that only some organs, every cell in our body has this gene knocked out in one, or in some way deficient in one allele, and it has to wait for the other allele to get knocked out. But why only in the colon in the APC, or why only in the retinal and I think that Sriram has explained it quite well. You see that every gene, although it, in this case the retinoblastoma gene, has such an important part to play in the cell cycle, it's not only a question of being important in the cell cycle, it is when is it important, at what stage of the developing cell. Okay, you know that we don't get retinoblastomas in adults. Okay, retinoblastoma and many of these syndromic things happen at younger ages. So the APC gene, you're not going to get an APC type polyposis only in adults. It starts very early. It starts, I wouldn't say that it starts at the age of 2 or 3, but by the time the individual is 12, polyps have already started developing, and you will get polyps that just keep on proliferating in that. So it's an early kind of story. So why does this happen early? It's because during the, as we see over here, developing tissues, okay, there is a particular stage in a particular tissue where that tissue becomes very vulnerable to the formation of tumors. And there's some interesting work that has been done. And I would say here, you see the second point, cancers initiate through the effects of oncogenic events only on susceptible cell of origin states. That means when the cell is most susceptible to this, and there are some cells that are very susceptible at a particular state. And here is a nice little paper. If some of you are interested, you can go and look it up. Yes, it was, you have the RB depleted. Now, suppose you don't have RB at all, and you have this maturing retina over there. Now, this maturing retina has got what they call the ARR3. Now, we needn't bother about that, so it's maturing. And then you have another ARR3 minus, which is not the immature ARR3, okay? Now, what happens is that you have these cone precursors, and as they enter into the cell cycle, they are proliferating. Now, in an RB depleted system, whether it's lost one or later on it loses two, in the Knutson's type of hypothesis, you find that it's only these ARR3 precursors that form retinoblastoma-like lesions. Okay, they actually form little benign tumors first, which are called retinomas, and we sometimes see retinomas in the human system, and they are almost invariably in patients who have a germline mutation in their genes. Okay, so it is about vulnerability again of cells or tissues where the cooperation of other cellular and tissue systems are required at a specific time point. So that's the reason. It is every cell in my body has this, but every cell in my body is not susceptible because of the fact that that particular gene, there has to be a combination of events that takes place in that particular cell for the this genetic event to initiate neoplasia. So that's the answer to that question. And I'm very happy, Sriram, that you thought about it and came up with a very interesting answer.
Thank you, ma'am.
All right, now here was the question number 3. Every one of us now does, and in many labs, I'm sure you know, that we are talking about and those of you who attended the talk on cervical cancer, somebody gave you a talk, and if I remember right, it might have been from PTI Chandigarh. Now everybody's doing P16 because we want to know whether this is an HPV related tumor or a non-HPV related tumor. And if you do P16, you will, as a surrogate marker for HPV, you are able to label this tumor, whether it's a squamous carcinoma or an adenocarcinoma. When it's occurring in the cervix, we call it, or we suspect that it is an HPV related tumor. We do the same thing in the oropharynx. Yeah, the oropharynx is also susceptible to HPV. Of course, a lot of our oropharyngeal squamous carcinomas are tobacco related. But in situations where tobacco is not part of the system, you find that HPV has a strong association with cancer, squamous carcinomas of the oral cavity. So tonsil, base of the tongue, supraglottic larynx, epiglottis, these are all oropharyngeal tumors, okay? Oropharyngeal squamous carcinomas, and we look for P16. So why do we look for P16 in the system and use it as a surrogate marker for HPV? Do you know what is the meaning of surrogate? Sonal, what's the meaning of the word surrogate? Is Sonal there? Sonal?
Yes, ma'am.
All right. Well, what is the meaning of the word surrogate? Do you understand the question? What is the meaning of the word surrogate? No, Sonal doesn't understand the meaning of the word surrogate. Okay. Is Akriti there?
Yes, ma'am.
All right. Will you like to explain to Sonal what is surrogate?
Ma'am, ma'am, it's a kind of a similar marker which can be used in others' place, like
A similar marker? You mean that it's telling you that it is a kind of a marker for HPV? You can use it anytime. Wherever it is used, it tells you that this is HPV. You think that's what it is?
no, ma'am.
All right. Let's ask Asma. What is the meaning of the word surrogate?
Supports the
Sorry?
main. It supports the main. Matlab, it comes as similar as the test.
No, surrogate means in place of. So you're not testing the particular thing that you're wanting to test, but you know that in a particular system, if you use this other marker in place of that, you have a high correlation between this marker and what it is that you are looking for. Okay, and so the correlation of using this marker in place of whatever it is that you're looking for has a very high correlation. Okay, so P16 can be used in many, it's actually a cell cycle marker. And we did talk about P16 yesterday. Sorry, 2 days ago when I was telling you about the retinoblastoma protein. How many of you actually realized it or went back and tried to think about it? So is there anybody there, like maybe Raghav, you want to talk about P16?
Ma'am, in case of HPV, actually E6 and E7 are involved.
I can't hear
E6,
you, Raghav, and I doubt that anybody else can. Maybe you need to be loud in close to the mic.
Am I audible, ma'am?
Yes, you are much better. So maybe you should push your
case
chair
of,
up. Yes?
Ma'am. So in case of HPV, the E6 and E7 are involved basically. So E6 degenerates the P53 while E7 does away with the RP.
All
Now
right.
P16 is very important for the cell cycle because it inhibits the CDKN2A, which is again important for the RB activation. So if RB gets knocked out, P16 gets accumulated or overexpressed, and in these cases, that is why we can get
Yes.
a high P16.
Absolutely, and I think
The IC
Raghav
will be
is
positive.
absolutely right. Okay, P16 is something that is an inhibitor of cyclin, CDK4 and the other cyclins, which are actually which promote hyperphosphorylation of retinoblastoma protein. And if the retinoblastoma protein is hyperphosphorylated, then it releases this factor, which is known as E2F. And E2F then binds to its transcription site, and you get, Asmita, please don't ask for, for annotation. Anyway, so, and then you get transcription. You can see that here in this, let me see if I can get my pointer to the laser, and you see that here. In this particular thing, you can see exactly in this diagram, you can see what happens, all right? If the cyclins are not in the system because P16 is inhibiting the cyclins, then retinoblastoma protein remains bound to E2F, okay? And then you are, you do not get transcription. And that's how the retinoblastoma protein actually regulates the cell cycle. Now, what does HPV do? And Raghav told us very succinctly what HPV does. And you can see that over here, either here in this particular diagram or over there. What HPV does is that once it is integrated into the genome, that's one part that Raghav, you failed to mention, that just having HPV in your cells in the episome, that means it is lying in the cytoplasm, this cannot happen. For HPV to be, to actually, have its effects so that you get a tumor, HPV has to be integrated into the host cell genome. Once it is integrated in the host cell genome, then it has its effects, particularly if it is a high-risk HPV. The high-risk HPVs have two genes, okay, which code for proteins, and these proteins are known as E6 and E7. All genes have their effects through their proteins. No gene can do anything inside the cell without being translated into a protein. Okay, it has to make RNA at least, but if it's a gene, it has to be translated into a protein at the other end. So there are these two proteins, E6 and E7. Now, E6 inhibits P53, so that's one mechanism by which it promotes tumorigenesis. The other mechanism is that it inhibits RB, either directly or through the inhibition of P21. One way or the other, okay, P16 accumulates in the system because there is no negative feedback. So if in a system, like in the oropharynx or in the cervix, you are expecting that there is going to be HPV carcinogenesis, yes, because we know that now. We know this, that there is HPV carcinogenesis. Then we can use P16 as a surrogate marker in place of actually looking for HPV DNA in the system, because it's so easy. We can use an antibody against P16, and if it shows up in a tumor where you are expecting HPV to be in the system, there are many tumors, like for instance, you have a serous carcinoma of the ovary. it overexpresses P53 and P16. But that's not because there's HPV in the system at all. Okay, it's just overexpressing that because of the fact that P53 is mutated and therefore not doing its job, and P16 is therefore being overexpressed, but not because HPV is in the system and that the E6 has knocked out that P53. P53 is mutated in serous carcinoma of the ovary, and that's the reason that you have P16, accumulating in the system. So once again, Raghav, would you like to tell them again the story of this so that people understand? Raghav, are you there? He's disappeared. Maybe his. All right, Sriram, can you repeat what you just heard?
Yes, ma'am. So given that we understand that the presence and the function of P53 in HPV tumors and non-HPV tumors, we have to understand that in one set of tumors where due to the presence of HPV, the P53 is knocked out, and that is why we have P16 overexpression. While in the other set, it may be due to any number of other causes that knocks out that P53, and that the confusion between overexpression of P16 should not be had.
So there are two reasons with HPV. One is, it knocks out P53 by inhibiting it by the E6 protein, and it also has E7, where you have the RP protein has been knocked out, and therefore it accumulates a lot of P16 in the system. Okay, but P16 can accumulate in any tumorous situation apart from it being infected with HPV, because it's just part of the cell cycle, and anything that causes P53 inhibition is, whether it's a mutation or some other reason why P53, or for that matter RB, is not being allowed to function, then P16 will be overexpressed in that system. All right, are there any questions on this? Are there any questions in the chat box, Loma or Vatsala, on this?
One question is
Yes.
from Shreyans, that
Yes.
why growth factors got secreted.
Which growth factors? He's talking about here? Yeah, so why did growth factors? There are growth factors that are always there, no? EGF and PDGF, and we are talking about, this is not in a tumor situation. What we are seeing over here, in where you can see my cursor going, all the way from there down here is normal, right? So if there are growth factors that are stimulating a particular system in any cell, lots of cells have to proliferate, lots of cells have to function. So there are always growth factors, and those growth factors activate the cyclins, okay? And the cyclins hyperphosphorylate retinoblastoma and then E2F. So in any cell system, if you want growth, then obviously it has to be the growth factors that stimulate growth. And in such a system, P16 is out of that system because the growth factors are active. If you have growth inhibitors, then P16 comes into the system to stop growth in any kind of cell. Does that answer the question to whoever asked? Because we're talking about normal growth over here, where I have now got my cursor. This is normal growth inhibition. This is normal growth activation. So you need to have that happening in all cells. Growth starts, then it has to be inhibited. That is our way of the cell cycle. Okay, so how did it get into the system? It is there in the system anyway. All right, so Shreyans, I hope you have understood that this is not, I'm not talking about tumors, I'm talking about normal here. And here is what happens when you have HPV, E6 and 7, which enter into the system. All right, so I'm go on now to the last question. And who wants to take that question? Asma, you're in Tata Hospital, right? And you see a lot of squamous carcinoma? Yes, Asma? So now you answer this question. What is the pathogenesis of squamous carcinoma?
From what I understand, ma'am, that it is
Loudly, Asma, speak into the mic.
yes, from my understanding, it is multiple. It has multiple steps. There is a stimulus, so there is a chronic stimulus which damages the epithelium, which lead to, in some cases, metaplasia. Then it will convert into dysplasia if the stimulus continue, and then the dysplasia will be mild, moderate, severe, and then it will transform into squamous cell carcinoma.
Okay,
So
Asma.
it,
Very good. All right. So according to you, all squamous carcinomas happen that way. Yes?
but in squamous epithelium, metaplasia step is not there.
Ah,
But there must be some stimulus.
there must be some stimulus. Do you know any stimuli?
Uh, chronic injury, matlab, there is
Chronic
ulcer, and
injury,
then
anything else?
in lung cancer we have matlab, smoking and injury to
Smoking,
the
all right.
UV
You know,
radiation.
yeah, Asma, think about the question, okay? This is the pathogenesis of squamous carcinoma, okay? How many questions are there in that one question? There are two, I'm telling you. There are two questions in that one question. All right? Can you spot the two questions? And you were answering it, and then you stopped because you suddenly talked about metaplasia and then said, but everything is not metaplasia, no? So what are the two questions, Asma, that are there in this one question about the pathogenesis of squamous carcinoma? And while Asma is thinking, anybody else wants to think? Ajit,
HPV
what are the two
associated and
questions?
non-HPV associated.
Ma'am,
Sorry, who was it? There's a talk. Who was it? Okay,
I
Ajit,
was
come
saying,
on.
ma'am,
ma'am,
Yes, Ajit.
yes, ma'am. Ma'am, what I understood is that pathogenesis of squamous cell carcinoma will vary as per the etiology. Like
Fantastic.
just
Very good.
uh,
Yes, Ajit.
uh,
So
like
one
just we
is
learned,
etiology. Yes.
ma'am, just like if it is HPV associated, just now we learned. Now the
Yes.
HPV is regulating, down regulating the RB and P53.
Okay, excellent.
Similarly, suppose we talk about UV rays effect causing skin cancer.
Excellent.
That causes pyrimidine dimers and defect in nucleotide excision repair, and that will give rise to squamous cell
Excellent,
carcinoma.
Ajit. Very
If
good.
we talk
So
about urinary bladder,
Ajit, this was one question, etiology, right? So in this
ma'am,
pathogenesis of squamous carcinoma, one of the questions is, what is the etiology of squamous carcinoma? And what is the second question, Ajit?
second question is what that etiology does to our molecular system. What
Well,
that
don't
leads
you
to.
think the second question is, where does squamous carcinoma occur?
Yes, ma'am. Site also.
So where the site is,
Site. Yes, ma'am.
wherever you have two questions over there, Asma. You agree? And the first question is, where does squamous carcinoma occur, and what is the etiology of squamous carcinoma? All right. Once you know the answer to these two questions, then you can, each of those etiologies, carcinogenesis occurs in different ways. Okay, so now if you want to look at the etiology, look at this. Okay, there is all on the left hand side are the places where squamous carcinoma occurs. And on the right hand side is carcinogenesis. Skin is UV radiation, and you just had Ajit talk about DNA adducts that are occurring as a result of UV effects on DNA. You talked about chronic scarring and inflammation, whether it's burns, varicose ulcers, etc. So constant breakdown and repair, breakdown and repair. That is also producing, you produce a squamous carcinoma over there, and we'll see what is actually going on when you have chronic scarring and repair. The cervix, we just talked about, that's HPV. We have the nasopharynx, yeah, which is EBV, and EBV has got effects on proliferation, on genes that are involved in proliferation. You know that. For instance, in Burkitt, c-MYC is an extremely important gene, and EBV acts through this proliferation of through c-MYC. Then you have the nose and paranasal sinuses, where you get squamous carcinoma. Chemicals, those who are working in some of these industries, and of course tobacco. Oropharynx, it's HPV and tobacco. If it's the buccal mucosa, it is smoked and smokeless tobacco. And also, if you have tobacco combined with submucous fibrosis, then there is a whole new ball game going on. Then in tongue, larynx, lung, you have tobacco, it's smoking. There's also alcohol, which is involved in the esophagus and the tongue. And in the urothelium, urothelium, there is chronic calculus disease, which can cause squamous carcinoma. And if you are a chronic smoker, then the urothelium is also susceptible to urothelial carcinoma. Okay, so that is when somebody asks you a question, if you have understood what that question actually means, then the answer to that question is very easy. You agree, Asma?
Yes.
So that is the pathogenesis of squamous carcinoma. Now, before we go to the next part, this is what you were trying to talk about, Asma. You were saying that you have an inciting agent which acts on squamous epithelium, and through a whole series of other pathways and other events, it becomes a squamous carcinoma. If you have non-squamous epithelium, it goes through this squamous metaplasia, the stage of squamous metaplasia, and then you get squamous carcinoma. Yes, so if you think about it in this way, I don't think you have a problem about answering such a question. Okay, you won't find it written as pathogenesis in your textbooks of squamous carcinoma, but you have to be able to answer questions while you are on your feet. Okay, good. Now, what's happening here? Why doesn't my thing move? It should. Yeah, okay. And this brings me to epidemiology and carcinogenesis. And, you cannot be ignorant about what are the different kinds of tumors that we see in our country, and what in general is the epidemiology of tumors. And in epidemiology, we don't know much. We know a lot about all this, the environment, chemical exposure, radiation, this and that, but we forget the host. And in the host, age is a very important factor in epidemiology, and so also is reproductive history. There are very few other host factors that we can take into account. Everything else is in this environment and lifestyle and so on and so forth. Okay? And I just want to show you, and you should know, that we have in this country, at least we have 18 regional cancer registries. Okay? And each of these cancer registries produces data on what are the or what is the incidence of all of the different cancers, and incidence is quoted as how? How do we quote incidence? Akriti, how do we quote incidence of cancer? See, there are figures there, right? You can see the figures? Akriti?
Yes, ma'am.
Right, so what are those figures? Are they, what is it, percent? 9.8% for trachea, bronchus and lung in the Mumbai Cancer Registry. Yeah? What are those figures? And down the line, see, look at this now. There is in stomach, in Mizoram, you have 47.2. What is that? 47.2% of the men in Mizoram have a stomach cancer. That means 50% of them are healthy and 47% have stomach cancer. What are these figures, please? What is the denominator? Akriti?
Ma'am, denominator should be the total number of cases of that of carcinoma of that particular organ. Like if it is a
No, so give me an example. Take any one of these. Now take trachea, bronchus, and lung in the Mumbai Cancer Registry. You see 9.8 there? All right, give me the denominator. Akriti.
Ma'am, denominator should be the population that are at the high risk.
Population that is high risk. So how do we know
That are
which population is at high risk? Huh? Akriti? No. Sonal?
Ma'am, denominator is target population.
Target population. Oh, okay. So that if there is, say, in Mumbai, how many million people are there in Mumbai, do you think, Sonal? They are the target population, right? So how many million are we? 18 million people in Mumbai. So it's 9.8 out of 18 million, do you think? Sonal?
No, ma'am.
No, ma'am. All right. Priyanka, are you there? Priyanka, are you there or have you, is your internet unstable? Are you there, Priyanka? No, Priyanka is not there. All right. So let's go to the men. Ajit.
I think per persons getting cancer, denominator is persons having cancer.
Persons having cancer. So you should know all the people who have cancer, and then you say out of them. So if there are 100 people who have cancer, 9.8% of them have got cancer of the trachea, bronchus, and lung. Is that what you're saying?
Yes, ma'am.
Okay. Sriram? What is the denominator? This is important, friends. You know, we know a lot about HPV and we know a lot about all sorts of things, T cells, B cells, etc. But this is something that we cannot afford not to know. Okay. Is there anybody who is asking, who has said anything in the chat box, Lopa? Before I ask Raghav.
Ma'am, they have described like Shreyas has said per 1,000.
Per 1,000.
Yeah.
Okay.
Leera said per 1 lakh.
1 lakh. So 100,000. Okay. Then?
Shreyan's also repeated 1 lakh.
So that's 100,000. Yeah. Okay. Raghav? Who do you agree
Incidence.
with? Per 1,000, per 100,000? Or, you know, the population like 15 million? Or as somebody said, total number of cancers, and then you know how many are stomach, bronchus, and lung. Yeah, Ajit?
Incidence
Are you
could be
doing a little
calculated for
Google
total.
search? Huh? It's 100,000. Okay. So these figures are for 9.8 per 100,000 males. Okay. In females, it would be breast. In Mumbai is 32.7 per 100,000 females. Okay, so that is always the denominator. Okay, and it tells you how many of, and it's a high figure. 32.7 is a high figure. 47.2 is a high figure. Okay, so this is how we go. This is, there are field workers. Field workers go collect data. They don't go and inquire with people. what they do is that they go to different institutions, hospitals, they go to registries where people die, deaths are recorded. There are huge, a whole lot of different places. They go to your medical college departments, anywhere where records are kept. They get the names, they get the other information that they need, not only the type of the cancer, but the age at which it has occurred, and so on and so forth. And then they match these according to names, so that it's a very big exercise. Running a population-based cancer registry is a huge exercise. But without that, we would not know what the incidence of cancer is in any population. And why should we know what is the incidence of cancer in any population? Yeah, anybody like to tell me, Sonal? Why should we know this? Why should I bother to know that in Mizoram we have stomach cancer?
It helps us to
That is
start
a
screening
yes?
procedures.
Screening procedures. Who said that? Raghav. So Raghav thinks it's important so that we know whether we should screen for these cancers. If it's a very low thing, we shouldn't worry to screen for those cancers. Anybody else? It's not just, yes, who was answering? Come on, a female voice. Who's that, Sonal?
Ma'am,
Who's it?
Ms.
Akriti?
Yes. Ma'am, to evaluate the risk factor at a particular area that are causing an increase in cancer so that we can control them.
Very good. Yes. One is to, the purpose of epidemiology, and what this is collecting epidemiological facts. The purpose of epidemiology is to first establish whatever it is. It may be the epidemiology of cancer, it may be the epidemiology of viruses, it may be the epidemiology of diabetes. It doesn't matter. What do you need this epidemiological data for? And yes, I can't remember who it was, Akriti, I think,
yes, ma'am.
who said. Sorry, is it right?
Yes, ma'am.
So Akriti said it's because if we know what, cancers are very prevalent in a community, then we know, or we should try to find out why they are prevalent in that community. Okay, so what are these factors that are responsible for this high, this incidence, whatever, high incidence or other factors as to why it is low in some community and it is high in this community. So what is it about the community where it is low? Number two, somebody said we can use it. That's Raghav who said that we can use it to actually screen for these cancers if there are screening procedures that are easy to do. I can't screen easily for cancer of the esophagus, can I? No. And yet, you see in Tripura, cancer of the esophagus is the second most common cancer over there at 6.8. All right. Is it very easy to screen for cancer of the trachea, bronchus, and lung? No, it's not very easy. Okay. Yes, you may take X-rays of the chest, and maybe you will do it only in high-risk individuals, etc. But certainly for cancer of the esophagus or cancer of the stomach, it's not an easy job. So, but nonetheless, screening is an important part of why we need epidemiological data. Anybody else has got any ideas? Anybody's writing anything in the chat box?
Associated with the environmental factors?
Yes, so that's what
Like,
said. Environmental factors.
Kangri cancer.
The etiology. So that's exactly what Akriti said. If we know that there is a cancer that is prevalent, we can try to find out why it is occurring. All right. Anybody in the chat box saying anything? The third reason is trends. Okay. Now look at the trend over here. Take Tripura. Okay, take Tripura and you see cervix in females, cancer of the cervix is 10.1. Okay? It is the leading cause of cancer in females in Tripura. When you come to a place like Mumbai, okay, you see what is the leading cause? It is breast, 32.7 And once upon a time, let me tell you, the figure 32.7 in Mumbai was for cervix. And now, 25, 30 years down the line, it has switched. Breast has become the leading cause of the leading cancer in females in Mumbai. All right, it has switched places with cancer of the cervix. So we know about trends. Now, once we know about trends, then we can find out why has this trend happened? Why is cervix cancer going down and breast cancer going up? So again, we have to look at factors. Is it something to do with the environment? Is it something to do with lifestyle? And so on. Well, this is not my job over here to tell you all about this, but this epidemiology is extremely important. Okay, like we found out about tobacco and squamous carcinoma at different sites. This came from epidemiological factors. Okay, right. Now this is just something else that I put up, and we need not bother about it as long as you get the drift of what I'm talking. Now, that was the answer to all of those questions. Now let us go to neoplasia part 2. Okay, this is the stuff that did not arise necessarily from the questions that I asked. Okay, now this was my understanding of cancer 40 years ago. It's exactly the understanding of cancer that you find in most textbooks even now. Okay, but we have to examine, and we did examine the last time in neoplasia part 1, what was cancer, and we said it was a malignant neoplasm, and we also talked about the deficiencies in the system, in the definition rather, of what a neoplasm is. Yeah, and I cannot repeat it now because it would just take too much time. So we said that we also understand that cancer is a multi-gene growth disorder caused by somatic mutations. Yes, that is what most people believe. You see it in your Robbins, you look up any other textbook that you read, and you will find that this is what is said, and that these somatic cancer arises from the clonal expansion of a single neoplastic cell. Okay, and we did say that most neoplasms are clonal. We didn't say all when I was talking, but that's it. And we also said that an amoeba cannot get a cancer, talking about clonal. And then we talked about cancers exhibit defining hallmarks. And we went through all of the hallmarks. Now let us see whether this actually is as we understand it. Okay, and I think that we have to believe that this somatic mutation theory, we are asked to believe that this is the prevailing paradigm for oncogenesis and tumor progression. And what does this theory say? That there are heritable, and once again I tell you, this is not about heredity, meaning what is coming in the germline. It is just when one cell divides and gives rise to a daughter cell, that daughter cell inherits its genome from the cell that is dividing. So a liver cell or any cell in my body, the genome is exactly the same, and this genome is kept constant when one cell, stem cell, or whatever you want to say liver, skin, or whatever, when it divides. Okay, not only does that happen, but my liver cell is a liver cell. It doesn't look and behave like my skin cell. Can anybody tell me why? Although it has the same genome. Yes, every cell in my body has the same genome. Do you agree?
Yes,
Asma,
ma'am.
do you agree? Asma? Is Asma there, or is Asma?
Yes, ma'am. Yes.
All right. So Asma, does your liver cell have the same genome as your skin cell?
Yes, ma'am.
And why
But
is your
the
liver
genes which
cell?
are expressed and suppressed,
Correct.
they
So
are
you are
different.
right. So there is gene expression. Now you know that the liver cell doesn't go back to its primitive stage and then do this gene expression. So whatever the gene expression that is taking place when one liver cell becomes the next liver cell, that cell also inherits the marks on the genome that prevent some parts of that genome being expressed and allow some parts of the genome to be expressed. Do you understand that, Asma?
Yes.
Yes. So it's not just having the same genome, it also has the same epigenetic marks. And it's not my place to talk about epigenetics over here. Go and look up what is epigenetics. Okay, there are marks. There's methylation, there's histone deacetylation, whatever it is. So this prevents some genes from being expressed and allows other genes to be transcribed. Okay, so these are the heritable changes that occur in the genome of one cell, which gives rise to a clone of descendants, and that constitute the cancer and display all its biological hallmarks. That's what you and I and all of us are asked to believe. And then it is mutations accumulate in cancer cells over time and lead to tumor progression. And you see very nice diagrams that are in your textbooks, and I've copied a diagram which is very iconic and which is there in your Roberts. Okay, so in other words, cancer is a multi-gene disorder that begins as a clonal alteration in a single cell, and almost all cancer research and therapeutics is based on this thing called the somatic mutation theory of cancer. Okay, this has got nothing to do with the germline. All right, and this is the iconic picture where you get clonal heterogeneity. So it starts as a normal cell, then there is whatever stimulus, in this case carcinogen induced mutation, and we call that an initiated precursor cell with stem-like properties. Okay, that means that this cell can now keep on responding to growth factors and being uninfluenced by tumor suppressor genes. So it is slowly getting accumulating the cancer hallmarks, okay, acquisition of the cancer hallmarks. Then you have additional driver mutations, you have a founding cancer cell, and then there is further genetic evolution. Go and read it. It's all there in your textbooks. And these additional mutations, there are subclones, and I explained that to you. Some of these subclones may have metastatic potential, but whatever it is, the tumor is becoming, starts out as having one mutation or just a few mutations, and ultimately it becomes genetically heterogeneous cancer. All right, so that's the theory. Okay, and this theory has been put to the test once it became possible to take different parts of the tumor and analyze them genetically. And this was a very seminal paper that was published in the New England Journal of Medicine. Now it's a long time ago. It's almost 10 years that it came out, where they looked for intratumoral heterogeneity and showed, just like we have evolution in nature, in biology, all over, the tumor is also undergoing evolution. Okay, so it starts out by some kind of driver mutation, and slowly there is branched evolution. And in the end, you may get either a metastatic tumor. Here you see the M part, or different parts, because this is a renal cell carcinoma, so it's R1, R2, R8. I think they took 8 different bits from this renal cell carcinoma, and each of those had a different genotype as compared to the other parts of this tumor. But there was always one thread that was running through it, and that was the original mutation. Okay, so this seemed to really prove the point that a tumor starts with a somatic mutation, acquires a lot of genetic mutations, and finally becomes a clonally heterogeneous cancer. And this is used in liquid biopsies. Has anybody heard of liquid biopsies? Yes, Raghav, you know what is a liquid biopsy? Have you
Detects
heard of a liquid biopsy?
cancer circulating cells
Very good. Yes,
in the blood.
there are circulating cancer cells. Yes, it's not just circulating cancer cells. They're circulating DNA.
Genome, DNA.
Every cell in my body, when it is disintegrating, and it doesn't have to be a cancer cell. Cancer cells are just disintegrating at perhaps a faster rate than many of my normal cells. Yes, senescence occurs in all kinds of cells, and therefore you have circulating DNA as well as circulating cells. And the circulating DNA of the cancer cells are obviously not the same as the circulating DNA of your normal cells. So if you know what the DNA of a tumor is, you can then look for those mutations in a liquid biopsy, okay? And then see whether that is exactly the same or there has been some other additional changes that have taken place in these cancer cells. Okay. Now, yeah, this is not just theoretical. Okay, it has a meaning. For one thing, if a patient has got more than one place at which the tumor is, say you have a lung cancer and now you have several metastases, you have them in the bones or you have it in the liver, and you want to know whether those metastases have acquired other mutations. Particularly, people are interested in resistance mutations. So you're treating that lung cancer with some kind of targeted therapy, usually, or sometimes with chemotherapy, and you want to know whether all the metastases have got the same genomic type as the lung cancer, the original tumor. Now, it's a hell of a job, biopsying all these multiple tumors. So one way of getting a comprehensive view of what the tumor changes, DNA changes are in the tumor is just to collect a liquid sample and then run it through a genomic analysis. You will find the original genomic alterations in the tumor. And then if there are additional genomic alterations, it doesn't matter where they are, in which cancer, or whether it has occurred, which cancer, meaning in which metastatic tumor, or maybe within the main tumor itself. But it may tell you that you can't use the same drug to hit this tumor because it has acquired a resistance mutation, and that is done quite routinely to look for resistance mutations in targeted in genes which are the targets of, or their proteins are the targets of various kinds of targeted therapies. All right. But here is another very interesting thing, that you have done surgery on a patient, okay? Colorectal cancer. Colorectal cancer is very, if you can do surgery, there's nothing like it. So you do surgery on this tumor, and then you have to make a decision as to whether you should do adjuvant chemotherapy. That means give additional chemotherapy. Now, you would like to do that, but chemotherapy is toxic. So you have to choose which of these patients who are at stage 2 should receive adjuvant chemotherapy and which not. Because if you give it to all people, you're producing unnecessary toxicity in all of these individuals. If you're giving it to too few, you need to choose which of these few you would benefit from it. Okay, and this is a very nice study that was almost 4 years in the making, and the results were announced in 2022, in which they found that after surgery you wait for 6 weeks or 8 weeks and then do tumor circulating DNA. If there is no tumor DNA, circulating DNA, this patient, see, you can see the curves that are separating over here. Yes, post-operative cDNA positive, and these patients do very badly. And they do that even in clinically low risk patients. Okay, clinically high risk, anyway, they're supposed to do badly, but even there, you find that those with the postoperative circulating DNA are doing even worse. So this is one way of predicting patients who have got a good prognosis and do not require postoperative chemotherapy versus those who, if they have circulating DNA, you can choose. Okay, so that's just one thing about liquid biopsy. Now here we've seen this wheel before, and in this wheel we have put all the different, this is again a very iconic figure which came from Hanahan and Weinberg. That's a misprint which has come not from me, but has come from Robin's textbook, because this is directly taken from there. So what do you see? Each one of these different hallmarks today is targeted in the clinic, okay, by various different drugs and mechanisms. And so you will say, yeah, look, if there is hallmark is angiogenesis, we can have inhibitors of VEGF signaling. Take EGFR inhibitors, because EGFR is a growth factor. We talked about it last time. It sustains proliferative signaling. So target the EGFR with a tyrosine kinase inhibitor and it works. Telomerase inhibitors. Here we have, now we use venetoclax, which is a BCL2 inhibitor, and so on and so forth. Okay, all of these, and therefore those who advocate this kind of somatic mutation theory says, see, we're right. This SMT actually works in practice. So good. So that's why we are expected to believe all this. Okay. But there are a lot of nagging questions with this somatic mutation theory. One of them, and we'll talk about it in a little while, and that's the origin of therapeutic resistance, especially to drugs targeted at driver mutations. I will tell you about it. There is organ specificity in inherited cancer syndromes, and we just discussed that a little while ago. If these genes are so important, then why is it that every cell in the body doesn't get the cancers? And we answered that question a little while ago. Okay. Now this is even more curious, that cancer cells can be normalized. And this story of once a cancer and it's always a cancer, and then it is, and I'm not talking about benign tumors, I'm talking about cancers, and that there are mutations and there is clonal heterogeneity in these tumors. So if that's the case, then how are cancers normalized? And I'll talk about what is happening in these cancers that are being normalized, okay? But even more curious is that you can produce a cancer from normal cells which have no mutations at all. They're absolutely normal. And all that you do is that you transplant them into abnormal locations, and lo and behold, a cancer is produced. Now, that's a little bit difficult to square with this whole story of somatic mutation therapy. Okay? Also, and we know this, we discussed this, that cancers respond therapeutically to physiologic stimuli. So what is happening? If you've got such a wild cancer, why does it respond to physiologic stimuli? And then there are a whole lot of normal individuals who harbor cells with the genetic markers for cancer and do not develop cancers. And this is true for a lot of lymphomas, also leukemias. And you examine the blood of these patients and you'll find lymphocytes with the 14-18 translocation in very healthy individuals, and they never go on to get a follicular lymphoma. Similarly, there are patients who have classic translocations of myeloid leukemias, and they never go on to develop a myeloid leukemia. And we keep on talking, oh, this is the fingerprint. 14-18 is the fingerprint of a follicular lymphoma. but the patients don't have a follicular lymphoma, and yet the lymphocytes in their blood are carrying the 14-18 translocation. So it cannot be just that you have a somatic mutation and that is, sufficient to develop a cancer. There is also the issue of cancer dormancy. Yeah, how do cancers that are merrily going along suddenly go to sleep? What is happening to these tumors, and why do they suddenly awaken later on? So many patients who have breast cancer and look apparently cured, 20 years down the line, a liver metastasis develops. So why? So obviously there were tumor cells in that liver, and now they have suddenly awoken, so to speak. And this is the biggest question that I think I always asked, and that is why cancers predominantly occur in late adulthood. When do most mutations, when are they most likely to occur? When cells are dividing, right? That's when you get mutations. You can't get mutations in cells that are quiescent. So when are these cells dividing? They're dividing in early ontogeny. That means in embryological and early life, when the cells are actively dividing, and mutations should be very common. And yet, when is the incidence of cancer highest? It's in late adulthood. So it's almost as if we have to be senescent enough to get cancers. Now, all of these questions are, need answers. All right. So let's take therapeutic resistance in cancer. How is this resistance acquired? And I'm sure all of you know that you get resistance in microbiology when, you use drugs, and the drug that is, the organisms that are resistant to the drugs, they die, and then some clones that are, when susceptible to the drugs, they disappear, and then there are some resistant clones that are in that population, and then they are no longer repressed by these by the antibiotics that you're using, and then they dominate the environment, and you have got, in microbiology, you have an organism that is resistant, and we know that, we are told that. All right, so this is the answer, right? These subpopulations may be so small to make them undetectable in the clinical setting, but once the main population has been cut down, these small populations are sufficient to drive therapeutic resistance and patient relapse. Yeah, that's true of microbiology. That is true also of cancer therapeutics. So we have to ask, yes, how do these subpopulations arise? Where do they come from? So they are obviously in that mix of tumors, okay? And they are different from the original population. So did they arise from that original clone, which was growing, and then you have this clonal heterogeneity? And amongst that clonal heterogeneity, maybe there are resistant clones. Quite possible that is what is going on. Okay, but is it also possible that tumors are actually multi-clonal in origin? And people are now beginning to believe that this is probably true at least in a certain proportion of tumors. And I'll show you some examples. All right. Now, people who have studied multiclonality have found that there are at least 53 different, and I've shown some of them over here. You need not go into to read that. 53 different types of tumors, whether they are benign or even pre-invasive cancers or invasive cancers, that have been shown to be multi-clonal. Okay, and here is the iconic picture, if you wish, which I just drew. You have something that is got the black are the resistant clones, and the gray are the sensitive clones. Okay, and let's suppose that this was a point mutation in exon 21 EGFR gene, right? And the T790 resistance mutation is present in exon 20 of the same gene. Okay, so let us assume that the gray ones had the exon 21, that was, the mutation that is actually making this tumor grow, and it is becoming very predominant in this tumor. Whereas the T790 resistance mutation is present in the cells over there, in other cells, okay? And it is overshadowed by the growth promoting activities of the point mutation in exon 21 EGFR gene, okay, which is simply driving that tumor to proliferate. So this is fine until something happens, and that, targeted therapy you are giving this patient just cuts down that population of the susceptible population, and then this T790M resistance mutation will rear its ugly head. So now tell me, why do we say that tumors are clonal? And the question is simply this: how is clonality actually determined? Does anybody or one of you know how people determine clonality? Has anybody read about it? It's there in all your books.
The expression of certain proteins, ma'am.
Sorry, who said that?
Sriram.
Yes, what did you say, Sriram?
The expression of certain proteins will determine.
Expression of certain proteins. That's going to be a little difficult, right? You know that there was the most common way of determining clonality before we started doing whole genome sequencing and karyotyping. Karyotyping was before whole genome sequencing, etc. Was X chromosome inactivation. Do you know what X chromosome inactivation is about? I won't be able to explain it, but you should know that there was a gentleman by the name of Murray Barr, and he had a student. The student actually, while he was doing his experiments, found that in every cell in a female, one of the two X chromosomes is inactivated. And that is called the Barr body. All of you know that? Yes, you should know that. So in every female, in every cell, only one X chromosome is being transcribed. The other one is not being, none of the genes on that are going to be transcribed, because women have a double dose of all the genes that are present on the X chromosome. Now, why do we use this for clonality? Because this inactivation of the X chromosome happens, one or the other X chromosome, okay, happens very early in embryological life. So after that, the progeny of each of those cells, so it is one X or the other X. One X comes from the father, the other X comes from the mother, okay? So this happens very early in cells in embryological life, and the progeny of all those cells will have either the paternal allele that has been, a paternal chromosome that has been inactivated, or the maternal chromosome, okay? And thereafter, there is no more chromosomal inactivation that is just going on. So early in life, and this was found by this very, I would say, I don't think she ever got the Nobel Prize, but I'll have to check it. It was Mary Lyon, right? And so there is random inactivation early in life. And once that activation, and see, you can see it. If you have a red and a blue, one comes from the father, one comes from the mother, one or the other is inactivated, and all the progeny of these cells will have one or the other cell that is inactivated. So in any organ, you'll have some cells that have got the paternal gene inactivated, some cells that have the maternal gene inactivated. All right. Now you can understand that paternal, maternal inactivation when those cells proliferate, they will form a patch that will have just the maternal gene inactivated, and the paternal gene, which is inactivated, will form a patch, because that's how these cells will grow from their stem cell precursors. They will have patches, and this is very well understood that there are patches in all our organs, some of which, when I say all our organs, it's females that have this, will have some patches in all the organs, and it is very random. So you will have patches with maternal inactivation and patches with paternal inactivation of the X chromosome. Okay, now imagine that a tumor starts in one of these patches. Okay, and we'll talk about that. There are lots of other ways of doing this, but the early work, and to a large extent even work today, uses tumors that occur in females. You can't do this in males. Also, if you can look, not just look for patches, but you can also look for genes that are expressed on either the paternal allele or the maternal allele. You know, you can do it with G6PD, or you can do it with Humara, because that's where the genes are expressed. So it will be in one or the other of these, those who are heterozygous for these genes. You don't need to go into that thing, but now here I'll tell you. All right, now just take a tumor that is biclonal. Both these tumors are biclonal. All right, that means they have two clones, and I'm showing this as purple, and I'm showing this as light cream or whatever. They have occurred in a patch in which, let us assume that the maternal chromosome has been, X chromosome has been inactivated. Okay? Now, it is biclonal, but it is occurred in a large patch in which only the maternal chromosome has been inactivated. Now, imagine if you're going to do X inactivation to find out whether there is one or two clones in this tumor, what would you find? Anybody would like to tell me? I've said it over there, okay? There are two clones of tumors. That means this tumor has got this mutation, this tumor has got that mutation, but they are occurring in one patch. You will find that when you go and do X chromosome inactivation studies, A is going to be judged to be monoclonal. Why? Because the same X chromosome has been inactivated, because the tumors, there is a large patch, say in the liver, all of it with the X chromosome inactivated, but there are two tumors in that patch. One which has got one mutation, the other has got another mutation, and it's growing in that patch. You do X chromosome inactivation to see whether this tumor is monoclonal, and you will find that it is. But on the other hand, look here, it is biclonal, okay, but the patch is small. And if the patch is small and you are sampling from that tumor, you're going to see that one of the other X chromosome has been, the other one will show you a paternal chromosome inactivation, the other one will show you a maternal chromosome inactivation. And that's why this kind of clonality assessment has led to a lot of tumors being misclassified as being monoclonal when you use just this kind of X inactivation, depending on the patch size. I won't, dwell on this too long. You'll have to think about it before you do it. But this just tells you that we cannot rule out that these tumors don't have more than one. Now, using much more modern methods, more and more tumors are being shown to be polyclonal. And this was for a mesothelioma, but you can go and look it up. I mean, there are so many. And it says here, our results show that malignant mesothelioma, and they've tested many malignant mesotheliomas, originate as polyclonal tumors, and they suggest that the carcinogenic field effect of mineral fibers, that's as asbestos, leads to several pre-malignant clones that give rise to polyclonal malignancies. And I don't see any reason why this is not so. But it goes even further, and it says that the hypothesis that most cancers are of monoclonal origin is often accepted as a fact by the scientific community. Why? Because this dogma, that means this belief, rose decades ago through the study of hematopoietic malignancies and sarcomas. Okay? Because there you have these translocations, you have these mutations, and there is this clonal, now you can do it by flow, etc. But many solid tumors are perhaps more often than we suspect show you polyclonality. Okay. And if you think that that's only in mesothelioma, here is one for endometrial carcinoma. And if you think that that's the only one that now we've found it in colorectal tumors. So let us be a little less susceptible to this somatic mutation theory that says all of these tumors are clonal in origin and they all start from one. And I think that this is past its sell by date. Okay, so I think that a growth must develop. Oh, it could develop. And I think quite a lot of hematopoietic malignancies may do this. Okay, because we are using, like I told you, the 14-18 translocation, and you say that's the fingerprint of a follicular lymphoma. And it's, if I find a tumor and in that I find the 14-18 translocation, I say yes, that is because it is monoclonal. But does that happen always? And does it always happen in a solid tumor? I don't know. Okay, it must develop from a single progenitor cell in order to be considered neoplastic. I think that this idea has outlived its usefulness. Okay. On the other hand, lots of us think that if we find a clonal proliferation, it is by definition neoplastic. And so many people do this, okay? Just because there is a clonal proliferation, this must be neoplasia. And I think, tongue in cheek, I will tell you, each one of us is a clone, yes? From one zygote, some of us are benign, some of us are malignant, yeah? But I doubt very much that we are neoplastic. One zygote fertilized egg gave rise to every cell in my body. I am a clone, but I am not neoplastic. So don't believe that just because something is clonal, it is neoplastic. That is another fallacy that we have to guard against. Okay? Right. Now, how did that multiclonality develop? Did it develop from one cell, which then became clonally heterogeneous, or was it, like they said in the case of the malignant mesothelioma, is there a field effect? And that field effect, multiple clones are all developing? Well, we don't know, but I don't think it matters. As long as we know that there is the possibility that a tumor is not just made up of one clone that will react or respond in the same way in every cell in that particular clone. All right, so now that I've, dealt with that, there is this other problem. And that problem is, we believe, and that's what we pathologists are supposed to, that's how we make our living, that there are consistent differences between normal cells and cancer cells. And we can see it, that a cancer cell is definable by and of itself. And we now think that we can define a cancer cell by its molecular makeup. So let's test that hypothesis. Let us see. Can you tell a cancer cell from a normal cell, and can you do it by the ultimate test, and that is molecular makeup? All right. Well, if that's the case, then we have to answer this. question. Okay. Once a cancer, not always a cancer. And I think all of us as pathologists have seen this. Hey, what happens in a neuroblastoma? And don't tell me, please, that a neuroblastoma is not a cancer. It is. If you don't do anything, about a child who has a neuroblastoma and you wait long enough, well, maybe some proportion of those neuroblastomas will actually become ganglioneuromas. But the majority of neuroblastomas will kill a patient, okay? But we know that you treat a neuroblastoma and what do you get? You start to get differentiation in the neuroblastoma, yeah? So why? Why does that neuroblastoma differentiate? Either spontaneously or by treatment. Why does a non-seminomatous, high-grade, non-seminomatous germ cell tumor, when it is treated, differentiate to a mature teratoma? It is not mature. It was an undifferentiated tumor showing, an embryonal component or a yolk sac component or whatever. And then you treat these patients and become mature teratomas. And if you think that this is just anecdotal or whatever, experiments have shown that you take teratocarcinoma cells, which would otherwise kill the animal, yeah, and take those cells and put them into blastocysts, which are from other, animals of the same species. So you do it you take teratocarcinoma cells from mice and you put them into blastocysts. And you know what you get? You get normal embryos. Now that's interesting, isn't it? That you didn't give any chemotherapy, you didn't do anything, like you see in humans. But what you did was you just took teratocarcinoma cells, which were going to kill one mouse, and you put it in another mouse, blastocyst, and it became a normal embryo. And this has been known for years. Now, this experiment was done in 1975. Okay. On the other hand, you can take something like malignant nuclei, because the nuclei are obviously, I don't think cytoplasms can be said to be malignant. The genetic makeup of any tumor is in the nucleus. You take the malignant nuclei of a tumor, okay, and you put it into enucleated oocytes. You take an ovum, obviously we do it in animals, we're not doing it in human beings, and you take out the nucleus of that ovum, and then you transfer the malignant nucleus of a cell, which is, and you know what? You don't get a malignancy over there, you get normal embryos. Now that's very interesting, isn't it? You take teratocarcinoma cells and put them into blastocysts, and they form normal embryos. You take nuclei and put them into enucleated oocytes, and you get normal embryos. So what is actually happening? Think, okay? It's got nothing to do with the nuclei. It's nothing to do with the actual teratocarcinoma cell, which has obviously got the abnormal nuclei. So what is it that is quietening this down and actually making this, stopping the malignant behavior of these cells or even the nuclei? Okay, and here you have the last example. You take mouse mammary cancer cells. They are cancer cells. There's no doubt about that, because it comes from a cancer that would otherwise have killed the mouse. Then you take it to another mouse and you clear the mammary fat pad. You take out all the epithelium from that fat pad and just leave the stroma in that fat pad. And you put those mammary cancer cells in there, and what happens? It forms normal ducts. The cancer just disappears. Now, can I ask any one of 6 of you, what do you think is happening over here? Why is this thing happening? You've got malignant tumors which are quietened by doing these experiments. Anybody like to tell me? Sriram?
For a cancer to progress, we need a driver mutation and then followed by some
passenger mutations for it to continue acting like a cancer. A single
But it's
cell
already
cannot
occurred,
be.
Sriram. It's already occurred. There's a
That's
driver mutation and passenger mutations because this has come from a growing tumor. So it's already occurred. And we're taking the nuclei in which this has already occurred and we have put it into a system which
there's
just
ma'am,
makes
maybe because there's a change in the environment and hence a change in the
so it's got
stimulus
nothing to
that
do with the tumor. It has
no,
something to
it's
do with the environment.
environment, which is
Oh,
allowing
that
for
is so that is the real question. Okay, this makes you think that it cannot be about the cancer cell alone. This is a cancer cell, yes. There is a mammary cancer, there is a teratocarcinosarcoma, there is other kinds of tumors, which when you take them from the environment in which they are growing and you transfer them into an environment which is not from the environment in which they are growing, and they get quietened, which suggests, and that environment doesn't kill them because it's an enucleated oocyte and you are getting a normal embryo. So this oocyte has actually got just one nucleus now, and that nucleus is come from a malignant cell. So it cannot kill that because it's actually growing. It's growing into an embryo. So it is not about, the blastocyst killing these cells, or that the mammary fat pad has now got some T cells and other things and it's killed these cells. No, because there was no epithelium there, and yet the cancer cells have now produced normal quiescent mammary epithelium. Okay, so it's got to do something with the environment. And on the other hand, now here is normal tissue. You take that normal tissue, normal mouse embryos. Now you just take an embryo from a normal mouse and you implant it into a normal mouse testes. And you know what happens? It produces a teratocarcinoma. All right? It's absolutely normal. So why should it produce a teratocarcinosarcoma? But it does. Okay? You take the same teratocarcinosarcoma and you reimplant it into a normal mouse blastocyst, and the teratocarcinosarcoma just disappears. It becomes normalized. You take normal breast ducts and put it into a fat pad which you have radiated, which means you have initiated it. And what happens? Those normal breast ducts become cancerous. So it's not the epithelium of the normal of the normal ducts that were there, because they've been removed. It's only the stroma that was there, and that stroma had been initiated. Okay. And if you think that this is only, this is happening in animals and all, I think we are seeing it in human beings. Okay? Cancers are being produced by inert foreign bodies of a particular site. And you know that ALCLs are now very well known at the site of a silicone breast implant. And people are seriously wondering whether the silicone breast implants at one time should be removed in patients who have silicone breast implants, because it is not anecdotally that you got an anaplastic large cell lymphoma occurring at the site of a silicone breast implant. And there are more and more cases in very chronic wounds, etc. You are beginning to get tumors which you would not otherwise expect to see there, not like squamous carcinomas and things. You're beginning to see ALCLs. Now, why should you get an ALCL at the site of a chronic wound? Okay, so there is something else that is going on. Dormancy. Cancer cells go to sleep and they reawaken. And what is it that is actually happening? It is the stroma. It is the microenvironment. If it is healthy, can make stromal cells. So if you cut down the number of cancer cells by chemotherapy or targeted therapy, etc., you might suddenly find that the tumor has become dormant. And it's because you never kill the last cancer cell. It is the body and the microenvironment that makes that cancer, controls that cancer. Yeah. It's when the environment changes, and that environment changes for a variety of different reasons, that cancer may once again become active. So now we have established the fact that it cannot be just the tumor cells. There is something else that is required to allow the growth and propagation of that tumor. And there are ways perhaps of making that tumor go to sleep. And now a lot of people are beginning to say that we ought to be thinking of another theory to, this somatic mutation theory may not explain everything that we know about neoplasia. And there may be, some other theory that might explain it better. And this was a very tongue-in-cheek paper, but it was quite influential, which said that each individual cancer cell and carries no recognizable molecules or structures. Why? Because normal cells can become cancers, okay, that make them consistently distinguishable from normal cells. Because normal cells, when you put them you put them at a different site, they become cancers. And there are cells that are frankly cancerous and that you put them into another environment and that. So what is that one consistent thing that says that if it is there, it will be a cancer? The answer is, it doesn't seem to be that one consistent thing, okay? So here they argue that the differences between normal and cancerous states are not identifiable at the level of the cell, but identifiable at the tissue level of biological organization. Okay? Therefore, we should stop trying to look at just the cancer cell. We should look at a cell or any cell in the environment in which it functions. So that is why they talk about the death of the cancer cell, not apoptosis. Okay, and they have formulated, and who's the they? This is Sonen's, these two individuals, and they have got more followers now, Soto and Sonnenscheid. Okay, and this is the tissue organization field theory. You know what they say? That cells are kept quiescent. All our cells have the property to proliferate. But what is it that keeps them quiet? It is differentiation. So what they say is, quiescence is achieved by cell differentiation and tissue organization. And that's what I tried to get you to understand when we were talking about the definition of cancer. All right? And this, listen to this. In a multicellular organism, reproduction of the organism is handed over to germ cells, right? Yeah. All other cells have their reproduction controlled through a process of differentiation. But if you say go to a sponge, for instance, every cell in the sponge is able to is able to grow, and it is not differentiated into different. But multicellular organisms like us have done this, and I think that they believe that cancer is better studied by systems biology rather than this reductionist science of just studying the cancer cell. Okay? And we talked about Hanahan and Weinberg. They're slowly coming around to the theory. They haven't abandoned their somatic mutation theory, but they say that the biology of tumors now have to be understood not only in terms of the cell, but the tumor microenvironment, okay? How much that contributes to tumorigenesis. And I don't know how many of you know the famous quote by President Clinton. When he was asked what is wrong with America, he said it was the economy stupid. And in this case, it is the environment that's stupid, which we are not paying attention to. So what is it? Is it the somatic mutation theory or the TOFT, that is the tissue organization field theory? And I don't think that they are mutually exclusive. Okay, it has to be that these theories are not mutually exclusive. And I think that there is this evolutionary perspective that we have to keep in mind. I believe that almost every biological system is better understood by understanding evolution. And this is what I mean by evolution. It is adaptive, adaptive natural selection. Now, here, I already showed you this thing, that lying in a tumor there are clones. It may be one, it may be two, it may be more, right? And that this is the evolution of the tumor, where one clone has got an advantage in a particular environment. When that environment changes, that clone that had the advantage then loses its advantage, and the other clone becomes dominant. Okay? And this is what natural selection is. It's the process of differential survival. I know we talk about survival of the fittest. Okay? In a particular environment, the animal or the organism that is fittest will reproduce and produce many more progeny. But when that environment, and it will become stable, but when that environment changes, then you cannot guarantee that that organism, and in this case, we are talking about cells, will maintain their dominance. And I just showed you how, and the little red streaks over there are the environment. It may be chemotherapy, it may be a change in your immunity or whatever, and you find that the cells that were dominant no longer remain dominant. Okay, all right. So natural selection, as I said, acts also on somatic cells, and we know this. Individuals or clones that are not adapted to an environment are eliminated. I told you that a mutation normally that increases proliferation, like for instance c-MYC, pushes the cell into apoptosis. That's what's happening normally. Okay, but then why do we get tumors? And here is a good example. You know that you have what is called mismatched repair deficiency, in which there are obviously mutations that are happening continuously, and mismatch repair genes, they are trying to repair that particular genome. If it doesn't, then the cell is pushed into apoptosis. So why is MMR deficiency, which you see in some of these cases, the famous multiple colon cancers without polyps, that's hereditary HNPCC.
Lynch.
Yes. So you get HNPCC, but you don't get as many tumors if you had mutagen exposure. And this is true. You have mutagen exposure and you get many tumors, and you get them quickly. And the answer lies here. Mutagens are both carcinogenic and also toxic to cells. And when a cell dies, it leads to regeneration. And in MMR deficient cells, we just said, apoptosis prevents neoplasia when mutations arise. But with mutagens, apoptosis has to be turned off, because there is death that is happening and regeneration has to occur, and as a result of which the cell cannot be pushed into apoptosis. So this is, to me, a very, very interesting thing. And long, long ago, Forjacq said this: cancer is a wound that does not heal. So if you have constant irritation, constant repair, and constant regeneration, you are going to get a time when there is all of the different states that are required to come together will produce a cancer rather than, this repeated attacks, the response of a wound when it is healing and then repairing and breaking down and healing all over again. This tells you that the environment has a lot to do. And if you can't turn apoptosis off, then you are in trouble. Did you know that elephants don't get cancer? Well, this is just to keep your attention going, because an elephant has, it's a huge body. So if it's got a huge body, it must have, to get to that size, it must have had so many cell divisions. Therefore, it should, it's more susceptible to cancers. When it has at least, how many, it has 20 copies of the P53 gene. We have only one. Which makes just 2 proteins. Well, they make 40 proteins because you have copies on each of the alleles. And that's why you knock off one P53 gene in an elephant and it's not going to get a cancer. Okay, so HPV can try hard. It's very hard to knock off all the P53 genes in an elephant and it won't get a cancer. All right. Now that brings us to age. And now that we've talked about the environment, you will understand why age is a primary risk factor for cancer. Okay? We don't get cancers at young ages, except when you have hereditary genetic, sort of problems in your genome, because natural selection controls the microenvironment. All the cells that are likely to cause problems are eliminated. But when that microenvironment, because when we are young, what nature wants is reproduction to occur. Once, the age for reproduction is past, nature doesn't care whether you live or die. And the age-altered microenvironment exerts different selective processes. I told you, you can, that a youthful microenvironment would have. And, we add to it by our inappropriate diet, smoking, stress, etc. And then the stable microenvironment is destroyed, and you can get clonal expansion of phenotypically altered clones. And this, Hanahan and Weinberg are now saying this, as I told you before, it is the environment stupid, okay? So it is not just the cells, it is the environment. So why should we know this cancer paradigm? Is it Toft, is it SMT, etc.? Now there are reasons, because there are direct consequences, because there are approaches to therapeutics. To modulate the cancer cell, should you modulate the cancer cell, or should you modulate the environment, or should you do both? Because when you try to modulate the cancer cell by chemotherapy, you know what you're doing? You're also modulating the environment to the detriment of the environment. You're trying to kill the cancer cell, but you're also killing the microenvironment. And then that's not able to repair itself and therefore keep the cancer under control. Approaches to prevention. Should you reduce exposure to carcinogens and modulate the macro or microenvironment? I think we should do both. And approaches to cancer research, for which you need systems biology. And I think the spin-offs of this, you get a better understanding of the processes of normal growth and development. And today, we are going away from this first thing. We are still doing this day in and day out, switching from first-line chemotherapy to second-line chemotherapy and third-line chemotherapy until, as they say, the patient's demise, or the clinician runs out of options, or sometimes the patient runs out of money. Okay? So now there is a lot of, I would say, attention to what we're calling metronomic therapy, low-dose anti-angiogenic therapy, immunomodulatory therapy, and targeting individual, sort of environmental and cellular components of the tumor. What are the preventive strategies? You give anti-inflammatory agents to patients who are at risk for Barrett's esophagus, and you find that you lessen the number of cancers that occur in Barrett's esophagus. And what have you done? All that you have done is stop the inflammation. Therefore, you're stopping the repair, regeneration process. Similarly, you treat hepatitis B, C, and you prevent, or H. pylori, and you prevent gastric and hepatic cancers. And so we have come full circle. We thought we knew everything. We thought that by studying the cancer cell, we were going to be able to cure cancer. Now, I don't think we are able to cure cancer or even understand cancer, because it's far more complex than that. And we do need another. And this is something that was said years and years ago, in 1962, by David Smithers. He was one of the most prescient, cancer researchers. He was a radiation oncologist. And he said, which is very true, cancer is no more a disease of cells than a traffic jam is a disease of cars. You see a traffic jam, there's a whole accumulation and more cars being added to this. He said a lifetime of study of the internal combustion engine, which is what we talk about, the nucleus that is actually making the cells, and it's mutated and it's making the cells, go crazy. We talk about rogue cells. A lifetime of study of the internal combustion engine would not help anyone understand our traffic problems. Yeah. So, cancer, I say, is like a traffic jam. It can be about crazy cars, crazy drivers, any one of these things. Go down and you'll see weather, bystanders, systems, traffic department. You sometimes have funny traffic departments. You have nakabandis. We have it in all of these. Any one of these can cause a traffic jam, and it has nothing to do with the car. Okay? So that is what we have to understand. It is not only about the cell. It can be very much about the environment. Sometimes it can be only the environment that leads to the formation of the cancer, as in the case where you transplant something from that is absolutely normal into an abnormal environment. Okay? So what is it that I have learned? I don't know what you have learned, because you're too young to have learned anything. I've been at this now for more than 40 years. I believe that cancer is a process by which an organism like phenotype evolves over time, because it is. It's almost like another organism transplanted or grown from your own body. It has everything. It has its angiogenesis. It is able to metabolize. It has its own systems over there. It has managed to co-opt the environment to its own ends. And I believe, which I've said more than once, that cytology and morphology alone do not define a cancer. Okay, behavior does. And I really do believe that cancer may never be defined at a molecular level, because, as I said, there may be nothing wrong with a cell and it may still produce a cancer, because the environment has changed, and the environment is not necessarily abnormal at the molecular level. Okay? Cancer research, I think, has taught us more about normal biological processes than about cancer itself. We still don't know everything about cancer. And I believe this, that cancer is about us. It is about our attitudes to life and to the environment. If we disrespect our own lives, we disrespect the environment, then we're bringing a cancer upon us. And I do also believe that cancer is one of the consequences of senescence. We were never meant to live as long as, That is not what nature wanted us to do. Okay? We have artificially improved our own lifespans, and we are very, very, very happy that we have done. And I don't see any reason, as long as we're healthy, why we should not live long. But that is not what nature wanted us to do. Nature in general wants that once your reproductive lifespan is over, then the next thing should be senescence, and the consequence of senescence is death. Okay, we are about the only animals in this world, and we are animals that live much longer than after our reproductive years are over. Okay, so that's what I wanted to say. And I will also end with this. Every sort of contradiction can be found in cancer. So don't believe that if you know something that tomorrow you will not find it contradicted. Cancer, I believe, is like life. If you think you have understood it, please think again. Because I don't think that any of us understands life, leave alone being able to define it. So definitions of things like cancer and life are going to evolve over time. So with that, I will end this talk. Thank you very much, all of you, for having. Let me just get out of this thing. Yes. If there are any questions in the chat box, I'm happy to take them. Or if there's anybody else who wants to add to this, I know that towards the end it was philosophical. But you sometimes need to get philosophical to get at the answers, okay? And you can't take things for granted. This somatic mutation theory is there in all the books. You never hear much about the other kinds of theories that we might want to consider, particularly when we want to manage a patient with cancer, okay? Because this all has. There is a reason why we need to understand the underpinnings and the biology of whatever processes disease processes that we are studying. And cancer is just one disease process. Okay. So anything's in the chat box? I can open the chat box myself, I suppose, and see.
Ma'am, there was one question.
Yes.
How are we able to maintain the HeLa cell lines till date, considering all these theories?
How are we maintaining the HeLa cell line? Because the HeLa cell line was one which is continuously, it is one of the most unstable lines that you have. So if you get a HeLa cell line, anywhere from it has been maintained in culture, it will not have the same genome as another, because it is continuously undergoing, it is unstable, and so the mutations are continuously happening in that cell line. So it is maintained. It's an artificial environment. It has no stroma. Okay, perhaps if they put the HeLa cell line into an embryo, you might find something else turn up. There is no stroma, so you can maintain a lot of cancer cell lines, because all that they're doing is being stimulated by growth factors. And if you have a very unstable cell line, then it will continue to grow without any issues. Are there any other questions?
Ma'am, is there any example where therapy has actually changed because of this new theory, ma'am? Or we're still experimenting on it?
Oh, yes. Are you talking about, this is not a new theory. It's been known for a very long time. Yeah, so I'm telling you, there's now, just go and look it up. There is metronomic therapy. Metronomic therapy is being practiced at Tata Memorial Hospital. Asma, I am pretty certain that you will have heard about it because people talk about it, okay? And what is metronomic therapy? Metronomic therapy is about being kind to the microenvironment. Yeah, whether you're using low-dose anti-angiogenic therapy or metronomic therapy, you do not blast the tumor by huge doses of whatever anti-tumoral substances, whether it's radiation therapy, it's chemotherapy, or even targeted therapy. Okay, you give, you do smaller doses and you give its dose dense. That means you don't give the tumor a chance to regenerate, or in between, or that was the whole purpose of giving these and you allow the microenvironment to do its job. So that is what metronomic therapy is all about. Immunomodulatory therapy, of course, is another form in which you make the immunity of the individual, whether by checkpoint inhibitors or whatever, make it stronger against the multiple antigens that the tumor is now presenting to the immune system. Okay, so it is not just fanciful, it is actually happening. And I think that there's
Right.
a lot of sense. There is a lot of sense. And if you have a what would I say, a kind of a predisposition to cancer, like Barrett's esophagus is a predisposition to cancer, yes? If you're able to, and what is Barrett's esophagus? This is a peptic, it's caused by this peptic reflux. Yeah, and what is happening there is metaplasia. It's a colonic metaplasia that is a form of regeneration to stop this peptic reflux from causing esophageal, so a mucinous epithelium, which is more resistant to peptic reflux, grows in the esophagus. Okay, but there is inflammation at the bottom of all of that. It's inflammation, and there is metaplasia. That's what's happening in your metaplasia. That's happening in the lung. Smoking, that is causing metaplasia, yes, and also inflammation. So you get two things together, metaplasia and inflammation, and you have got a deadly mix, because the environment is altered and the epithelium is altered. And as a result of which, you are asking for an abnormal proliferation to take place. So now they know that a way to lessen the incidence of cancer in esophageal, in Barrett's esophagus is give NSAIDs. So you give NSAIDs, you dampen the inflammation, and you stop the peptic reflux, and you have reverted this, this whole system. Similarly, you've got hepatitis B and C, and what is happening? There's inflammation and there's regeneration, okay? And that again is a deadly mix. And when you have inflammation and you have regeneration, which is exactly what is happening in the metaplasia situation, you are asking for, carcinoma. So you cut that inflammation down. And, you treat the hepatitis B or C, and that's it. Similarly, H. pylori. H. pylori you treat, and you get rid of two things. You get rid of lymphoma, and you get rid of carcinoma. Because, as I told you, mutagens cause inflammation. They also cause cancer. And they cause inflammation because they are toxic to cells. Cells die, and cells, there is inflammation, and apoptosis is turned off because cells have to regenerate. So once again, regeneration, inflammation, and you get no apoptosis, because once there is inflammation, there is regeneration, and apoptosis has to be turned off, because otherwise how can regeneration occur? And this is the deadly mix. And once you get that, then you cannot answer as to whether you are going to get a neoplastic change or not. Okay, so this is how we need to think about something that we have just taken for granted, because all the textbooks tell you some stories about you get mutations and this. Yes, of course you do. I'm not suggesting that you don't, but There's something else that we need to think about. Okay. Any other questions?
Yes, ma'am. Priyanka
Sure.
Vanashali is asking, can CDKs and cyclins be used as surrogate markers for HPV?
No, I know it's very difficult, Cyclin D1 has to again hang around long enough. Cyclin D1 you can detect if it is abnormal, just like P53. Okay, it has to be mutated to be able to do it. That's why you're able to see it in mantle cell lymphoma, because that is the problem. No, it has to be mutated or it has to be translocated, one or the other, and therefore you have huge amounts of cyclin D1 over there. Normal cyclin D1 is what's it going to do? Nothing very. But P16 is in large amounts being because P16 normally would have gone out of the system, but now it is constantly there because it's trying to suppress the cyclin D1 because of the negative feedback is not coming to it. Yep. Okay, so that's why we have P16. Anybody else?
Ma'am, I have a question.
Yes, very good. Who's that, Sriram?
Sriram, yes, ma'am.
Yes.
Ma'am, after having spoken of both these theories, when we
Yes.
talk about tumor metastasis, is it that the tumor microenvironment at the metastatic site is something induced by the tumor itself, or is it predisposed, and which is why certain tumors metastasize to certain sites?
Metastasis is a very active sort of thing, and it's written in all the textbooks, and I tend to agree. That is what is called the seed and soil hypothesis. Okay, lots of tumors might get into the circulation because they have the ability to do so. I mean, their adhesion molecules have changed. Many things have happened, and they're able to do this. They are able to dissolve the, the stroma, the
Barriers,
matrix,
yes.
etc. Right. They get in there, and they may even get out at various different sites, but they may not be able to grow because the microenvironment
is not,
allow
yes.
it to grow. Okay, so this is also something that we have to understand, that it is not just a simple matter of things getting into the bloodstream and then doing whatever is otherwise believed to be what is metastasis. There is truly a remarkable concerted effort. I don't think that each of ourselves is thinking, okay, but there is a whole mechanism to keep things in place. You know what Claude Bernard said? It was about keeping things stable, right?
Equilibrium,
So
yes.
stability at any cost is what the nature tries to do. But then if stability breaks down then for some reason or the other, we have the environment or the tumor goes out of control, then you just don't have much to say about it. But
Yes.
I just wanted people to understand that it is not only the tumor
The
cell.
tumor, yes, ma'am.
Yeah. And for years, I've been using this analogy, that the tumor is like a traffic jam. You've got lots and lots of cars, and you keep adding more and more cars, but it isn't the cars, my friend.
Themselves.
Maybe a whole lot of other things. Yes, it could be a car. It could be that the engine of one or two cars, or you happen to be in a place where everybody's driving a Maruti, and all the Marutis are not very stable, and they break down together. Yes, then it can be the car. It may be the driver. Maybe because he had a heart attack and he sort of collapsed at the wheel and then was in a situation. Yeah, but most of our traffic jams are not as a result of this. Most of our traffic jams are a result of many factors which have got nothing to do with the car. And that's why I thought that, it was such a wonderful analogy when he said it is, you can study the internal combustion engine, forever, but you will not solve our traffic problems by that, because it's not to do with
Very
And that's what we have been doing for years, studying the cancer
Cancer.
cell. Yes. So
Yes.
now it's high time that we did something else, okay? Than the cancer cell.
Yes.
Now, what did he say? Somebody said P16 can be raised in non-HPV tumors as well. Yeah, sure. But it does not signify the presence of HPV pathogenesis. You have to understand first that HPV is present in the system. I know that all cervical or the majority of cervical cancer, squamous and adeno, are HPV driven. I know that oropharyngeal cancer is HPV driven. Now I want a surrogate marker to tell me this in the oropharynx and in the cervix there is HPV in the system, and only then I can use P16. I know that ovarian serous carcinoma is not HPV driven. So then, but I know that ovarian serous carcinoma is P16, expresses P16, but it is expressing P16 because of the fact that P53 has been abrogated in that tumor. Okay, so there's another reason for P53 to be abrogated in that tumor. Okay, so I have to know beforehand, Kavya, that HPV is known to be in that system. I've discovered it by other research. Now I want an easy way of diagnosing that this is HPV related, and then I can use P16. Okay, if I don't know, I can't use P16 as a surrogate marker. That's why the word surrogate. Okay, I'm using it as a surrogate because I know that these group of tumors are HPV related. And so if I can find P16 in those tumors, yes, there is HPV in that system. Kavya, I hope you understood that. Okay. All right. There is something about, can a tumor create their own stromal environment? By using EMT transition. EMT is when the tumor becomes, when a epithelial tumor becomes, like a mesenchymal cell. So an epithelial cell becomes a mesenchymal cell, but it doesn't have to do that. It can still produce its own stromal environment. Oh, that's what it does. It produces angiogenesis because many of these tumors have dysregulated their VEGF. In other words, they should not be producing vascular endothelial growth factor. Yes, all cells are able to do this, but there is a regulatory mechanism that says that you have to shut off your VEGF. Say you're regenerating. Yeah, you need new angiogenesis. Don't we do that? When there is repair, you get granulation tissue. Where is it coming from? It's coming from cells that are regenerating, that are producing VEGF, and that VEGF is causing this, neoangiogenesis to occur. Okay, but once this has healed, then you have to shut off the VEGF. But if you don't, then VEGF is going to act as a growth factor. Okay, and those tumors that are signaling through their growth factor receptor, that's VEGFR, it's going to be able to produce more and more angiogenesis, like occurs in renal cell carcinoma, because in renal cell carcinoma you have the VHL gene that is abnormal, and the VHL gene produces or causes the production of VEGF and HIF. HIF is hypoxia-inducible factor. And then that's why renal cell carcinoma of the clear cell type just produces tons of leaky blood vessels. Because those blood vessels are not normal. They are very, very leaky blood vessels. And that's why renal cell carcinoma also has a tendency to metastasize through the bloodstream. Yeah. So there are, so of course, Okay, Kavya has understood. Very good. Thank you, Kavya. Okay, if there are any other questions, otherwise I'm always there on email. Okay, and I like interacting with people. Sometimes I learn a lot by your questions because then it makes me think. And sometimes I'm wrong and somebody points it out to me. Okay, so good. So now I think you can all go and have your dinner. Thank you very much. Thank you
Thank
to
you,
the
ma'am.
moderators,
Thank you.
Lopa and
Thank you.
Loma and Vatsala,
Thank you.
and
Yes,
to
ma'am.
all the students. All of you have been excellent.
Thank you,
Okay.
ma'am.
I thought it was important to ask the questions, do some homework, and see whether you guys have got a hang of what we talked about. So to all of you, Ajit and Sriram and Akriti and Raghav and Sonal and Asma and Priyanka, thank you very much because you were the ones who